now. President Obama in Atlanta speaking at the CDC, talking about the Ebola outbreak.
This medical team is at the center of work to try and reduce the time it takes to identify cases of the deadly virus, which continues to spread across swathes of West Africa. A lab established in Sierra Leone's capital this week can confirm if someone has Ebola in a matter of hours.
I'm Aubri Carman, a third-year medical student at the University of Arizona with an interest in infectious diseases, epidemics, and public health. I recently served as a National Heart, Lung, and Blood Institute short-term research fellow on a project in global medicine. Today we will be discussing the current Ebola epidemic and its evolution since it started in March of 2014. With all of the news and media hype about Ebola, it's easy to get caught up in thinking about Ebola in the United States. However, our mission today is to explore Ebola in West Africa from a basic science, clinical treatment, and societal implementation standpoint. As the epidemic continues, we have seen stabilization of case rates in Guinea and Liberia, while case rates continue to soar in Sierra Leone.
As far as we know, Freetown, the capital city, was the most recently affected urban center, meaning that cases in Sierra Leone may well continue to rise and then plateau, as we have seen in Liberia and Guinea. However, all of our predictions about the epidemic thus far have been wrong, making this epidemic truly unpredictable. As of December 18th, 18,603 confirmed, probable, and suspected cases of Ebola have been reported worldwide, with 6,915 deaths. Patients have been seen in 8 countries: Spain, the United States, Senegal, Nigeria, and Mali, in addition to the 3 core countries of this outbreak: Sierra Leone, Guinea, and Liberia.
How does the Ebola virus get into the blood? The virus enters through mucous membranes and breaks in human skin.
The virus first infects rapid response immune cells called macrophages and dendritic cells, where it then replicates and kills these cells, causing them to die. When these cells die, large numbers of virus particles are released into extracellular fluid. This fluid is then filtered through regional lymph nodes, where the virus can further replicate. From there, the virus goes into the blood and continues to infect dendritic cells, ending up in organs such as the spleen, liver, and thymus. The virus spreads effectively because it suppresses the immune response and kills the cells that it infects.
Once Ebola enters the body, how do we detect it? Detection of Ebola is based on a blood test using the polymerase chain reaction, or PCR, which is like a Xerox machine for genetic material.
The Ebola virus has specific genetic information encoded in the form of RNA. The blood sample is run through a machine that runs the PCR cycle, making millions of copies of the Ebola RNA if it is present. The key is that the things we need to start making copies, also known as primers, only bind if the RNA sequence is exactly right in the person's blood. Thus, we can quantify how many copies of RNA we have after we run the reaction. If someone has Ebola in their blood, there will be lots of copies. If someone doesn't have Ebola, we won't see any copies of the RNA we're looking for.
What issues are involved in the practical application of this blood test? We know that this PCR method is effective, but it's not as easy to implement in clinics in these 3 countries.
It costs approximately $100 to run one blood test using this method, and we need specific equipment that requires electricity, maintenance, and trained personnel that know how to operate it. Additionally, people working in the lab have to wear protective equipment since they are handling potentially Ebola-infected blood. Lastly, not all clinics have a lab, and the test takes 2 to 6 hours, resulting in significant delays between presentation and treatment.
How do we decide who gets this test? This test is clearly expensive, and it's not practical to test everyone in a given area for Ebola.
Focus testing has been implemented for the following groups of people: people living with or providing direct care for a person who was infected with Ebola or suspected to be infected, people who have had direct contact with someone with Ebola, even if they were wearing appropriate protective equipment, people who have handled bats, rodents, or non-human primates from endemic areas, and people who are symptomatic with fever, headache, weakness, muscle pain, vomiting, diarrhea, abdominal pain, or unexplained bleeding. Someone is not at risk for Ebola if they had contact with a person who was asymptomatic or not showing any signs of Ebola, even if they later went on to develop the disease. People are also at low risk if they have no known contact with infected persons. However, if someone in either of these categories shows symptoms of the disease, they should be monitored but not necessarily tested for Ebola.
What does the Ebola epidemic tell us about the social determinants of health in West Africa? The healthcare systems in these countries are rudimentary at best.
Liberia has 1 doctor per 100,000 people. Sierra Leone has just over 2 doctors for every 100,000 people. By comparison, the United States has 245 doctors for the same amount of people. Additionally, many healthcare workers have died from Ebola during this outbreak, making these figures even more drastic. The Ebola virus was new to the West African area, and thus not a lot of thought was given to testing people for Ebola early on. People traveled freely through porous borders and into big cities, bringing the disease with them. Additionally, Ebola patients require isolation, but the hospitals in these countries were not equipped with private rooms or secluded areas for infected people. Lastly, people from rural areas of these 3 countries have to travel far distances to clinics and treatment centers, increasing their chances of contact with others and a delay in diagnosis of the disease. Epidemics of the same strain of Ebola virus have been seen elsewhere in Africa and easily contained. So what's the difference between this outbreak in West Africa and the previous Ebola outbreaks? Healthcare workers in these previously infected areas are familiar with the symptoms of the Ebola virus, and thus they can promptly isolate suspected cases. Additionally, dead bodies can be properly handled using protective equipment if people are suspecting Ebola as a cause of death. Previous outbreaks have usually occurred in rural areas where people remain isolated along rivers or in tropical rainforests, without a lot of opportunity for trade, travel, and spread of the virus.
This outbreak took much longer to identify, and infected persons traveled, crossing local and national borders. Burials were not safe, and healthcare workers weren't protected from the deadly virus. How is health information distributed to the public in an epidemic like this? This is a difficult task, as many people do not trust the governments and health ministries in these countries due to previous corruption and conflict.
There's also a fear of Western medicine and reliance on traditional medicine or healers. Thus, our messages to the public in Western Africa must be culturally targeted to be effective. The lack of human resources and local health staff can make distribution of information very difficult. Hospitals become viewed as a place to go to die, and thus people can be reluctant to go into isolation or treatment centers even if they show signs of Ebola disease. Survivors can be stigmatized when they return to their local communities, when actually they could be the key to the cure by donating their plasma or blood to others who have the disease. Communication in these areas is also not easy. The internet is difficult to obtain, phone service is sparse, and radio communication is usually the best that can be done.
We found that roadblocks and checkpoints are difficult to successfully institute. Quarantines of large areas don't work well either, as people are paying bribes or taking unmonitored ways out of these areas. This is best demonstrated by a recent scare in the country of Mali, where an imam or an Islamic leader was able to enter the capital of Bamako by crossing the border by car from Guinea. He was able to bypass a checkpoint at the border by taking a dirt road. This is a great demonstration of how porous the borders between these countries can be.
There have been 7 confirmed cases and 1 probable case, the imam himself, of Ebola in Mali. 6 people died, and 285 people were monitored for 21 days. Luckily for Mali, there are no currently active cases of Ebola disease.
What have we missed while focusing on Ebola? As a side effect of the current Ebola outbreak, many other health issues have been overlooked. Because of the acuity of the Ebola crisis, many resources have been devoted to treating solely this disease.
While cases of cholera, malaria, measles, typhoid, and death during childbirth are all still occurring, with less resources to devote to these causes. Additionally, schools are closed, causing increasing rates of forced marriages and teenage pregnancy. Many orphan children have lost their parents to the Ebola disease, and people are becoming unemployed especially in Liberia, where 1 in 2 people are now out of a job. Tourism to these 3 countries has decreased, and all 3 are currently in an economic slump.
This outbreak is unlike anything we've seen in modern times. We're seeing a new disease in a new area with rapid spread, and the devastating effects that can ensue. Billions of dollars in resources and a global collaborative effort have been devoted to fighting this disease. Looking forward, it will be paramount to focus on the following questions. For example, the World Health Organization wants a blood test that can be done in 30 minutes in a clinic without lab facilities. There are already some prospects for something like this, but how long will it take to develop and implement them in a clinic? What progress have we made towards a vaccine for Ebola? There are currently 3 strong prospects, but none of them have yet made it to a clinical setting. How can we manage our concerns at home while distributing aid effectively to those suffering most in West Africa? A recent Wall Street Journal article suggested that U.S. hospitals are buying so much protective equipment for treating Ebola patients that there's a large unmet need for the equipment in West Africa. How can we improve health in West Africa using human resources and prepare these countries for an Ebola outbreak that could occur next year or 20 years from now? Moving forward, we need to use this unprecedented epidemic as a lesson in strengthening health systems in underdeveloped countries.